Well, hello everybody, and welcome to the latest edition of Infection Control Matters. Brett Mitchell here today, and I'm joined by a special guest from the United States, Associate Professor Matt Davis. Hello, Matt.
Hello. Thanks for having me.
Our pleasure. Our pleasure. Look, just by way of background, Associate Professor Davis is really involved in a whole bunch of work, but including that around spinal cord injuries. As the Associate Professor of Physical Medicine and Rehabilitation at McGovern Medical School in Houston. He serves on many advisory groups as Clinical Medical Director of the Spinal Cord Injury Service Line and advisory groups in the United States nationally. He's also the co-investigator of the Texas Spinal Cord Injury Model System and is a reviewer on several spinal cord injury-related journals. And today we're going to be talking about this interesting concept that I saw in a paper you've just had published, Matt, around Foley's and whether intermittent catheterization or indwelling catheterization increases the risk of UTIs. But before we even get to that, how did you get interested in this topic?
So coming at things from a rehab perspective, it's a very practical specialty. What affects people's day-to-day lives, and the choice of bladder management in spinal cord patients can have a really profound effect. So a lot of patients are not able to self-catheterize. And so if those people, are being catheterized by others, it's hard for them to leave the house when they want to take the kids to the park or whatever. They can only leave for 4 hours at a time, or they have to find a restroom that, both genders can go into sometimes, because often the caregivers are different genders.
Yeah, of course. Yeah. Yeah, so you started, you obviously got this interest in spinal cord injury, and then did you notice in your clinical practice your patients getting a lot of UTIs, and what was your
Absolutely. Yeah. These patients are very high risk for UTIs, and they have, and I think that we don't really necessarily have a great understanding of all of the reasons that they're susceptible. They have an impaired immune system, and one of the findings that didn't really come through in the article as much was that people who have highly spastic bladders, people whose bladders are very overactive. These patients have, extremely overactive bladders sometimes. Those patients were extremely high risk of UTIs compared to the other spinal cord patients.
Yeah, okay. And I know there's a lot of theories about why this particular population group are susceptible to UTIs. I guess one view, would you say, is that the frequency in which, of course, intermittent catheterization occurs is an opportunity every time for self-catheterization that bacteria are introduced. Do you think that's a reasonable statement, or do you think there's that and many other factors as well?
I think there are other factors. I think that it's preventing bacteriuria is really difficult in these patients. And so actually one study in the CDC guidelines, when you look at ways to prevent symptomatic UTI in long-term catheter users, the best evidence is actually to induce bacteria with a benign colonizer. And so it really kind of, has changed the way that I think a little bit, perhaps, about, the relevance and significance of bacteria.
Yeah. And what about diagnosing UTIs in their true sense, the true infection form in patients with spinal cord injury? You find that difficult?
Very challenging. There's, a lot of these patients do not have good sensation over their bladders, and then they can't feel the burning when they urinate, for instance. Pain, suprapubic tenderness, and so often they present with these very non-specific signs or symptoms, like increased spasticity, increased neuropathic pain. But even with that, some recent studies have come out that suggest that those soft symptoms, the ones that don't necessarily localize to the bladder, don't necessarily correlate very well with urine culture results.
Right. Yeah.
And so a lot of the things that I was taught as a resident in training actually is not all that relevant or useful.
And of course, the sort of broader definitions of UTIs, as you alluded to in this population group, are difficult because they're not going to have those sensations that others might have in different population groups that would then fulfill criteria of UTIs or symptomatic UTIs.
Yeah, I mean, the symptoms, if they don't feel symptoms, you could miss UTIs that are meaningful until they become febrile UTIs. And there's some argument that maybe those are the UTIs that matter. Most of these, I shouldn't say that most of these, perhaps most of these patients are colonized. Over the long term, they are colonized.
Which probably isn't
So
surprising.
the urinalysis will always show bacteria.
Yeah.
The urine culture will always be positive, and you can always have some vague symptom that you can attribute to a UTI.
Yeah.
And you'll check a urine and, oh, look, there it is.
Yeah, it makes it very challenging,
UTI.
doesn't it?
Yeah.
So moving on to this sort of concept of indwelling versus intermittent catheterization, what was your sort of initial interest in there? Were you with this sort of concept? Because the original idea put out is that perhaps indwelling urinary catheters are more risky in terms of UTIs than intermittent, but that's not what you're seeing in clinical practice?
That's correct. I mean, just to be clear, I think that, for people who are able to empty their bladders normally, so non-spinal cord patients, it's very clear that as soon as you're able to get the catheter out, get it out.
Yeah.
But for my patients, it's different. And so, we have here in the U.S., we have some changing policies, governmental policies that affect reimbursement and public reporting. So, for example, the hospital that I work at could be considered a bad hospital because we have a high CAUTI rate. Well, they were counting CAUTIs related in and out. They were counting CAUTIs related to indwelling catheters, but not CAUTIs for in and out catheter. You get those for free.
Yeah.
And I said, well, that's not really fair, I mean. And so the more I looked into it, the more I realized I don't think there's a difference here.
Yeah. And that led you to the systematic review that you undertook.
Yes.
And we'll publish the link to that on our website. So what was the question you were asking there in your systematic review?
The question was, is there a difference in UTI risk between indwelling and in-out cathing when you account for confounding influences? One of the things I saw was that so there's an immune deficiency syndrome that you see in these patients that is most severe early on in the injury. It's most severe in people with cervical injuries as opposed to lower down, and it's more severe in people with paralysis that's more severe. Well, that's the exact same demographic that we tend to use indwelling catheters in.
Yeah.
And so, to say with any degree of confidence you get more UTIs with indwelling catheters, you have to control for that confounding influence. And then also this, we talked about non-specific definitions of UTI. Another, potential source of bias would be if you have unblinded people assessing the whether they think this is a UTI or not a UTI. If someone expects that people with Foleys are more likely to have UTIs than people with in and out cathing, they might be more likely to attribute non-specific symptoms like we just talked about.
Yeah.
Might be more likely to attribute that to the UTI.
So via your review, were you specifically interested in the spinal cord injury population or more broadly?
For this particular review, I was interested in the spinal cord population. I have looked a fair bit into the literature in the general population. And I think it's pretty similar for, there are people with, men with large prostates, for instance. Some of them actually do need to choose between in and out cathing and indwelling. And, when you look at the literature on indwelling versus in and out in the non-spinal cord population, when you control for the duration of catheterization, I don't think there's a difference there. Now, using in and out cathing does often mean that you reduce the number of catheter days. So you can, for example, if you, some of these studies were done on people who had knee replacements, and they're just kind of waiting until the bladder starts to wake up and work again. Well, the people who are doing in and out cathing, they realized within just a couple of days that, okay, the bladder's working again. We can, stop, you can cut down on the catheter days, versus if you leave the Foley in for a week on everybody you put a Foley in, that's when you have a higher UTI rate.
Yeah. And that's some of the challenges when there's funding or penalties associated with things like CAUTI rates, where some of the interventions will try and drive down catheter days, and possibly quite rightly so.
Appropriately so.
Yeah. But of course, you're reducing your denominator in an incidence, which can have the perverse effect of actually increasing your rate overall. So that's a real challenge, I guess, in that space too.
Yeah.
So what in your systematic review, we won't worry about the methods too much because that's well described in the paper, and people interested in methods can read those. But what were your sort of key findings from your paper?
So the key findings were that, well, first of all, we found 24 studies that met our inclusion criteria. And we excluded studies that only looked at asymptomatic bacteriuria, for instance.
Mm-hmm.
And to be clear, when we compared in and out cathing to indwelling Foleys, there were a few studies that broke down in and out cathing by attendant for people who were not able to self-catheterize versus self-catheterizing. And we compared indwelling to cath by attendant because that's a more comparable group.
Yeah.
And so there are 24 studies we found, and only 3 studies found a significantly higher rate of UTI with in and out cathing. And all 3 of them had a critical risk of bias. So bias that you would expect to skew the results in favor of in and out cathing.
So overall then, your sort of general synopsis would be you couldn't find a major difference between infection rates, UTIs in people intermittent versus...
It was really interesting because I think that, when you look at recommendations in some of the guidelines that are out there that say, you should consider in and out cathing over indwelling, it comes from the spinal cord injury literature.
Yeah, right.
They're not citing studies on, men with large prostates. And so it really made me wonder, how did we ever come to this belief that people get more UTIs with Foleys? Because, we only looked back to 1980, maybe back in the days when they had latex catheters, things were different, or older catheter designs. But in the last 40 years, there have been, no studies that I would consider to be credible, given this bias issue, that really are anywhere close to convincing.
Very interesting. You mentioned in the systematic review that you excluded asymptomatic bacteriurias. I noticed when I've been looking at the literature, there'll be some papers that will call things UTIs. When you actually look at how they define a UTI, they'll just say the presence of bacteria. So how did you head in that, methodologically? Did you, if the paper said this is a UTI and used the word infection, but really when you drill down to the definition in the paper, it was just bacteriuria. Did you consider that as bacteria and exclude them?
Yes. Yeah. And so a lot of, and that's true because, I guess when people who might want to criticize this review might say, well, hey, here's a study on UTIs. And yes, so every time that we, most of these studies do have their definition of what constitutes a UTI. And if it was something that only required a positive urine culture and no other findings, then that was excluded.
Yeah. Yes, it is. It's a tricky one. I've had the same questions asked in stuff that I've looked at too. So what do you reckon the next steps for this are? What do you think that this is definitive enough, or do you think there needs to be, you mentioned no real high quality studies in recent times. Is there need to explore this more definitively now based on this review, or what would be your next step?
I think what I would say is if there's a difference in UTI risk between the 2 methods, it must be pretty small because there've been a whole lot of studies that are negative, and the difference in quality of life and just practical day-to-day issues that these patients face. Incontinence. Foleys eliminate incontinence or suprapubic tubes. Incontinence is practically eliminated. They outweigh any small difference in UTI risk. If there's a big difference, okay, then that's more of a discussion. But it's hard for me to imagine there is a really substantial difference.
Yeah, okay. And I was going to come to that about the other things. So we talked about UTIs as a primary outcome here, but there are a lot of other factors. If that risk is negligible, a lot of other factors considered, like quality of life measures. But in your clinical practice as well, have you noticed hemodynamic differences or the way in which the clinical management of patients might be different if that someone had an indwelling versus a UTI, knowing that there's some of those patients can rapidly deteriorate?
Yeah, to properly manage an intermittent catheterization schedule, you have to really closely monitor urine output and bladder volumes. And so for a substantial portion of these patients, they will have, like you mentioned, hemodynamic instability. They'll get autonomic dysreflexia if the bladder becomes overdistended. And that can result in blood pressures that really are hypertensive emergencies. They can lead to things like strokes and seizures. Usually they don't, but usually we catch these things before it gets that bad.
So I guess in the case of that, then indwelling would help negate some of those issues. Yeah. Do you find those very much in the early stages post-injury, or is that something that's going to be a consideration lifelong?
So dysreflexia actually is not often there in the first couple of weeks. It comes on, perhaps 2 to 4 weeks after the injury is when it can start to manifest itself. And it lasts lifelong. And so this is part of the issue. One of the things that really brought this to my attention in particular was the fact that we had neuro ICUs that were pulling Foleys in everybody because they wanted to get their CAUTI rates down. It was a financially driven thing. And so some of these patients came to spinal cord injury centers where we realized, hey, this is not sustainable to have this person on in and out cathing. It's time to put an indwelling back in. But a lot of them don't really have the benefit of going to a spinal cord center. And so we were seeing some of these people just kind of released into the world. And sure, while they were in the ICU, they weren't having this dysreflexia problem. But, we'd see these anecdotal reports of people who'd be coming into the emergency rooms with extreme hypertension, and some of them were having, strokes. And so that became an advocacy campaign for us as a spinal cord. Our professional societies have an advocacy campaign for that.
Okay. And in your clinical practice now, I won't ask you what your hospital policy is, but unless you want to answer that. But if you had your choice, would you be in favour more then of patients having the indwelling catheter as opposed to intermittent? Would you like that autonomy to be able to decide that as a clinician rather than be have something overhanging what you need to do?
Fortunately, I have enough autonomy that and have served on enough hospital committees, I guess, that I can have enough pull that we get to do what we think is best for the patients. And really, it comes down to patient preference and lifestyle. So for some patients, maybe they can't self-catheterize, but they just don't want a tube in their body. Okay, well, if that person has a caregiver available who's able and willing to do that, great. Some people, even people who are able to self-catheterize, they say, I don't want to deal with that issue. It's a hassle. It used to take me, 30 seconds to empty my bladder before my injury. And now it's really hard to pull my pants down while I'm sitting in a wheelchair. And so if we can't find an obvious benefit from an infection standpoint, then what are we trying to do here?
Excellent. Look, it's been a fascinating chat with you. I really appreciate your time, and thanks for your work in this area too.
No, thank you. I appreciate the opportunity to talk about the work.
Look, that's a wrap from us for Infection Control Matters in this edition. We'll put the details of the papers that Matt's authored and been part of on our website as well. But thanks very much for joining us, Matt, and thanks to our listeners.
Yeah, my pleasure.
Bye for now.